Okay. Welcome to the level 2 IDSC, and we are very happy to have you early morning with us. Today, the initial, can we discuss the concept we are trying to initiate the lecture with is, Doctor, you have to sit there because of the grouping. So what we are going to do is the first question that comes to you could be the longest article that has looked into the survival rate to the longest time. Do we have 5, 10? Do we have 20, 30, 50? Because we all know Brannemark started this in 60s, right? But then it was on rabbit. He did it on a human, and then actually who started collecting data. All that is a question. What is the longest article which can scientifically tell us how long these implants will survive? Do you have this question in your mind? Do you want to know the answer to this? Is this a triggering question? Yes.
I remember I read something that from Brainwash himself that
You have to talk in the mic because we are live.
okay. I remember I read something about Brainwash, the lengthy article, but he had some cases which has been successful over 28 years. So this much I remember. He wrote it, but not as a real academic article.
Yeah.
Be active only after keeping it indoors. Mine will be active only after keeping it indoors.
Oh, it will not be active if it's folded?
Yeah, because the sensor is not there.
Yeah? Okay. Thank you for letting us know. Okay, but we talk about a published article, which is a documented article. So the article you have in front of you is the longest tracked implants in the literature today. We don't have an article which is more than what you have this article in front of you. Okay? So what we are trying to do today morning is to make article reading more fun. So the introduction and the material and methods will be read by one group and will be explained to the group which have the results. And then the results will be explained to the group tell us the conclusion based on the result. So you do not have access to the materials and methods. You're going to get it from them telling you verbally. They don't have access to the conclusion. You're going to give them the results, and they are going. Is this the cause? And they are going to conclude based on the results. So let's hear the introduction and the materials and methods. Yeah. You ready to explain to them? First, say the article is written by whom and put it in your ear, then you're better than me. So tell us what is this article is all about. What's uh, the main theme of this article?
This article is about critical care outcome management that ensures they are using an osteointegrated dental.
Famous. The main you have to sit for there. The maximum duration of keeping a record of the survival rate. Okay.
Practice-based evidence associated with long-term outcome that is more than 20 years.
Can you be a little louder? Yeah, be louder.
Like study the long-term outcome of
They're listening to you. They don't have access to what you have. So if they don't get the information, they don't have access to what you're saying. So whatever they get from you is all the information they have. Go ahead.
purpose of this article is like to know about the long-term outcome, like more than 20 years. What will happen to cancerous patients who are having osteoarthritis tendonitis. This was conducted in Mayo Clinic, Ophthalmology Department, in a period of 1983 to 1991.
Okay, that's it. How it was done and all is not mentioned. They just collected the data.
Materials and methods.
Yeah, yeah.
There were a company of 255 completed CAD follow.
Maybe he should continue. Give him the mic. Give him the mic. Let him continue.
Materials and method. There were 264 patients who had at least one NHLS job identified. And out of that, 255 completed their care and follow. And out of that, 209 certified what medical and regular military eligible. The prosthetic outcome categorized as anticipated or unanticipated prosthetic and biology treatment. The effective intervention required for which was requisite to assess how to prevent dynamic for the care model.
Okay. Anything else you want to know about the materials before? You have any questions about it, you can ask them.
Related medical. 35 maxilla alone. 209 11 mandible. Yes, and 11 maxilla and mandible. Out of them, 255 completed care and follow-up. And 264 patients. 260.
Any other information you need to know? You okay with that much information? Because you're going to make the conclusion. All right. So let's hear, based on the materials and methods and the introduction, let's hear the results. Which of you are going to explain the results? Dr. Khan, you want to talk about the results? Or, yeah, go ahead. Sorry?
To guess the percentage or
Yeah,
guess the percentage.
yes.
At least one prosthetic event was
Yeah, what do you think? Based on what you heard, let's hear your guess as a team, and then the next group who have the conclusion, they have those numbers. Let's see how far you from the what actually was the result. Discuss the results, or you just want to is sitting more further than the team. Based on the materials and methods and what you normally expect as a result, what do you think is the average percentage? So what, so now they are guessing the information that you have. After they tell their guess, you will see how far they are from what actually was the result, and then based on all this, four of you are going to tell us what is the conclusion of this article. Yes.
This personality events is this just like talking about like a food now?
We got disrupted because there's not much going on. You made a unanimous percentage. Yes. Who's ready to announce? You made a unanimous. You all agree with the percentages. For you to this team, sure. Your team, you're supposed to be sitting next to him. You are introducing the materials and methods to the group based on what you said, because 8:30 was the. So they are making now the results. Based on the result, they are going to make the conclusion for the article which is in front of you. Yes. Hi. Good morning. Depends where you sit, you get a different article. So decide your seat. Okay, I think we have to listen to your opinion because time is running. All right, let's hear it. Okay, you have to really pay attention, and you have to pay attention to the real numbers versus the numbers you estimated. Ready? Go ahead. Let us listen.
According to our guesswork, like for the at least one prosthetic event in the range of around 30 years, give a percentage of around 30 to 35%.
32 to 35%. Okay. Before we continue, who's the speaker between you? So you are going to answer all the things. All of four of you should be in one.
This 35% is
What they're estimating
estimating
of the prosthetic failure. They're estimating. You have the real numbers. They have the estimate. They guessing. Go ahead.
So what I say is like at least one prosthetic event in the period of 15 years, we rate it at around, we give a percentage of around 30 to 35%. And at least one biologic event, because
Can you tell us what's a biologic event?
biologic event can be anything like bone loss, or there can be inflammation of the
Fantastic.
the patient will come with some pain.
Yes.
But prosthetic event, the screw loosening, cap coming off,
Yes. Or fracture of the
fracture of the
ceramic or whatever. Yes. Good.
so that's and the overall experience like the guesswork operation, implant failure in 13 years, so we rate it at around 3 to 5%.
Failure.
Failure.
Okay.
It can be due to any of the reasons like uh, local infections or biological causes, mainly biology, also even prosthetic design failure.
Okay.
It's like 3 to 5%.
Yeah, 3 to 5%.
How many years?
Over 20 years, 30 years, 13 years.
That's it? All the information you give? Okay. Now let's hear the actual results. This was what they expected out of, some of you have more experience than others. In a team of 5 with all their experience, after reading the materials and methods, they guessed this should have been the results. Now let us hear the actual results. Go ahead, doctor. How far it on? See, we are live, so if you speak, everybody can see you. Yeah. So now, how far their numbers was from the real numbers? What is the percentage of error you found between what was estimated and what actually was the result in the article? 58%. And what did they say? So they were thinking the failure rate and prosthetic failure rate is higher than what actually happens, or they thought it's lesser. So is that a good information for you now? But the people who were part of the introduction, information help you. Okay, continue then.
And biological is 32%.
Was failure.
Yeah.
And what did they estimated?
3 to 5.
So, okay, that's another. So again, the implant dentistry has a better results than what actually happens in the real life. So what was the percentage of error in the biologic from what is estimated in the public, what actually happens?
20, there is 28%.
So difference. So 28% more problems are expected than what you think when you go home, when you do a procedure. You know what you think and what happens. That's what we are trying to analyze today. Yeah? And what was the last thing? The last
86%
was survival rate. And what was your survival rate?
5% failure.
So 95% versus 85%. So how much? 86. What is the 9%? So it's not as far bad as, so the survival rate of what you expect is higher, but not as much. No, it's higher, but not as much as the prosthetic and the biological failures. You think prosthetically your work is much better than what actually your work is. And biologically, you think your patient will have a very nice surrounding soft tissue and bone around the implants versus what actually happens to the bone and the soft tissue around the implant. We're talking about 20% difference between what you think and what actually happens. Now we go to the end of the article, which is now based on your 4 of you, if you join them, 5 of you, you have to tell us what is the conclusion of this article. You are the only ones who have the conclusion. So after they tell what they think is the conclusion, you are going to inform them how far they are off from making a conclusion after reading an article. And then of course, this method, saying if you're in a group of 3, instead of being 1, and you divide the article into 3 parts, and then this way, Is it more interesting, more fun, and memorize? Ready? Go ahead.
We have to talk about the failure. There's two reasons. The conclusion should say that there's two reasons for failure. One because of the prosthetic failure and one because of the kernel cell failure. Here, we can note that the failure because of the prosthetic failure is because of the kernel and actually at least around 8, we collected it to be around 10%. One more thing we can discover that the growth in the failure is coming because this prospective study, so it comes at the end more later than the biologic and this logic. So we have to take care for the maintenance of cost of drink and these things. More, not more than, but we have to take care for the maintenance and this.
So his conclusion is biological are expected, prosthetic failures are expected later, and hence don't leave your patients after say 5 years have passed. You say if 5 years nothing happened, you don't have to come back for maintenance. It's actually the reverse. The more you wait, the more there's a chance of, so the maintenance become more important in prosthetic problems. I'm talking about maintenance in terms of coming back to check the prosthesis. And the biological maintenance, which is taking a periapical X-ray, checking the gingival inflammation, the bleeding index, all those biological maintenance, that is more to be emphasized at the earlier area. That was a good conclusion. Any other thing you want to add? Okay. Now we listen to the actual conclusion in the article. Who is wants to read the actual conclusion? I know you want to read. So tell them mainly what was the conclusion of the article, and before you tell them, what are the things in the conclusion that they did not pay attention to? Be loud. So this part they already said. The only thing is the 4 times he was not very much. Okay, so, but 4 times is a good thing to remember. So the prosthetic failures are 4 times higher than the biological. Continue. Okay. So one question was, what you didn't think of to mention was these prosthetic failures. What do they need now? Do they need just patch up? Do they need repair? Do they need full repetition from scratch? This is a financial issue, correct? This part you didn't say, okay, what happens to these failures? They already calculated even the what happens to these patients who have prosthetic failures. Can you read that part again? It's very important. How, what, the remakes were how many? 22 out of 255. Yeah, so 8% of them was total remake. Okay? Okay. So based on what you see, the article concluded, was there something now you want to think you missed, which was important? The last sentence. What?
That 10% failure loss of it's not an small
Issue.
percentage. It's very big percentage, even it's 1 year study. So what the last line says that we have to give more care about crosstalk for the long time.
Fantastic. Okay. So now I want to hear uh, your opinion on the method of studying articles this way. Analytically, what do you think reading an article in this way? How does it help or no? It's better to just read an article the usual way.
Depends where to this article. Here, it's better.
They cannot hear you. No, my point is if you guys, like three of you are friends, you sit down and read the article this way. One of you will only have access to you chop it in three parts, and then what is the benefit of reading an article in terms of you listen, expect what is the result, and then expect what should be the conclusion, and then compare between what actually happened and what you expected versus just get the facts and memorize it. What is the skill involved here in this method versus reading by yourself?
Usually reading by ourselves, we are reading in one package. We start from the beginning till the end. We just read. Our mind is not calculating, and so we just go to the conclusion and take the conclusion, and that's it. Maybe after why we forget in this. Now I will never forget that I calculate by myself and I took the conclusion by myself, so I will remember forever. And even my conclusion was same with the article. Let's say it was not the same, I will never forget this. So
Either
I think
way.
yeah,
Okay, good. So this is a method that you can read articles in a team if you like to. All right. This was the introduction of today. If there is any questions about this article, ask me now. Otherwise, we'll start the session. Level 2, as you all know, mainly concentrates in mandible, especially posterior mandible. So all the discussions which we will have today and tomorrow and day after will be on the mandible. We focus on it, we understand every bit of it. We don't leave anything related to the mandible in these 3 days. Okay? Come. Anywhere you'd like to sit. If you need more light, we can talk. All right. The other microphone is with whom? Okay, whoever wants to ask a question for other people who are listening live session, they need to use. Okay, familiar with the initial formation of the mandible. There's not much involved in implant dentistry, but as the person grows into a deciduous dentition, we all know there is more chances of losing these teeth, and there are accidents that happen to this age, and there are cases where children come to you for dental implants because of the accident, and that's the question you ask is When can I interfere in placing an implant? At what age? Now, we discussed earlier that in the literature, 16 years of age is a starting point for female, and maybe 17 to 18 is for male. That is not 100% based on literature. That is only based on experience of the doctors who have placed implant in children, and there was an overgrowth of the skeleton of the face of the patient, and they found that the implant has not moved and the face of the patient has. So that caused the people who made these numbers to decide 16 for girls, 16 plus for girls, and 18 for boys. A perfect number. So based on every individual scenario, we know the maturity or adolescence for girls. It could be puberty, it could be the signs that they show. For guys, it can be the voice. And from that time on, it's a time for you to decide if you want to intervene or not. The questions we want to ask and answer before the end of this session is, what will be the width of the implant, the height, what will be the occlusion, the relationship with the nerve, what will the mylohyoid fossa, how we will look for it. And when we place an implant in the mandible, we place it parallel to what? Parallel to the floor, parallel to the neighboring teeth, parallel to the mental foramen opening, parallel to what? And the placement level, it should be at the bone, below the bone, above the bone, soft tissue level. The spacing, welcome. Splitting and spreading, is it allowed in the mandible? Is it encouraged? What kind of anesthesia we will do? And what kind of grafting is different in the mandible versus the maxilla? Now, this is basically an age where normally you come and place implants. When the patient already has the wisdom tooth, that means they are above 18. So this is a safe age to come in and do your implant dentistry. Of course, unfortunately, this age people are not the ones who come to you. This category of patients are coming to you more often for implants versus an 18-year-old patients. So in these cases, what are the different strategies and what are the methods of providing implant dentistry for them is also a new method of implant treatment, which we will discuss. Let us look at one of the cases that are in terms of, I can say, the last category, where the amount of bone available is not sufficient to be able to provide the traditional implant dentistry. Okay? In this scenario, definitely it's very wise to measure the buccolingual width of the denture itself. That gives you the idea of how flat is the ridge. So this dimension is helpful for you to know, are you dealing with the wide? Because you can see the height in the panoramic X-ray, but you cannot see the width in a panoramic X-ray. So this gives you an idea till you have access to a 3D radiography technique. And of course, the interocclusal space, which will give you an idea how much of a room you have to provide the patient with different prosthetic results. For these cases, the maximum number of implants that you can provide will normally be the ideal solution. If you can provide implants to have a category of patients, definitely that is the way to go. Now the question is, a patient comes to you in 2018, normally not hoping for a removable prosthesis, because they are running away from the removable prosthesis that they had. And if you tell them, I'm giving you an overdenture, probably they will assume it will not be what they asked for. Okay? Now, for you to be able to, that it's choice that they have is a removable prosthesis, but also a removable prosthesis for them has an advantage where a fixed bridge cannot give them. And that is, what is that advantage? Sorry? Huh? Maintenance of? Hygiene. Hygiene is definitely a point, but there is something major in these patients. When you give them a bridge and you give them a removable, then only when they place both of them in the mouth, they will go for the removable. Exactly. At this age, they need to support all the muscles of the facial expression where it cannot be supported by a bridge. So actually, it's more advantageous to them to have a prosthesis which has acrylic. Now, if that can be fixed, like All-on 4 or All-on 6 hybrid prosthesis, where it has a pink acrylic or a pink ceramic to support the lips, I think that's where you should go for this category of patients. So don't jump in quickly into a bridge is ideal for everybody. As they grow older and they lose so much structure, they also lose a lot of, and the wrinkles in their face and the soft tissue. So sometimes we have to think of different designs for that category. One step better than that is the patients that can receive ideal size implants, sometimes in not the ideal position, but at least you have a normal length implants, and you can provide them with more stable, with better prognosis treatment. And of course, you have the patients who come to you with all the bone that you require. For this category, I don't think the question where to place implants, or it becomes in providing them this with the most maintainable number of implants without over treating them with just more and more implants. So basically, you want to have sufficient amount of implants to support a prosthesis which is maintainable, because 50% of that prosthesis after 13 years will be broken. Correct? What we just read? Yeah. You don't want to engineer something that are more maintenance than needed. So how you deal with the posterior mandible? Basically, with the first radiograph that you have, which is a panoramic radiograph, okay, you will determine the height from the inferior alveolar nerve, and you determine the width, 7 millimeter per implant, and you have always a radio opaque marker in your X-ray to calculate the exact amount of the planning. And based on this single radiograph, you get an idea of what to do. And then the patient sits on the chair. What are the 4 steps of diagnosis? Panoramic X-ray, like this. Then the second step is intraoral examination. You check it with your mirror, and you look at, and you ask the patient to close, and you see the occlusion. And the third step is, of course, his time, is taking medication. All that is done in that second step. The third step is you take your apps, you document, then you take impression for it, and the systematic way of 4 steps. It's very easy for you to make a treatment plan. Now, what happens from a developing dentition till as we, you're reading, put this in your ear and read. Read for us.
Extensive sensory input, development of motor skills and neuromuscular learning, dental alveolar craniofacial early adult dentition, dental adaptation is repetitive, three learned protective reflexes, deteriorating adult dentition, one partial to periodontal disease, ill reflex adaptation. Dentulous state, fringe reduction, compromised reflex adaptability, including movements.
Okay. So, what is your favorite time the patient will come to you? What do you prefer to see? You hope to see, huh? Healthy adult dentition. You prefer to see them at this stage, is it? Okay. And what is the percentage of edentulosum starting from which stage? I'm not talking about total edentulosum because you'll start from here and you go up. But partial edentulosum starts at what level? Like 1 in a million. Average patient who walk into your office, third level, second level, how many of these people come to you for implants? There are. Yeah. I think in our practice, what I've seen, this is mostly the people who start coming for implant treatment, not this. We don't see them unless uh, maybe very rarely. But generally, we start here, and nowadays, we are seeing more of this category. The reason we see this more of this category, the fourth category, is because they live longer. Now, these people, they get to live up to 85 years old. So that's why, so how to take care of this group. Yes, please.
So this have age categories.
Uh, Approximately, not a fixed, but there is an approximate age category. But it's not like exactly like every 10 years we go further or 20 years and you go like, no. But as average, you can estimate. Now, there is so many uh, powers that you have in your skills. For example, if I want to say, Anas, what is the main you're proud of? You must have something that you do. What is your
Again, the question.
what kind of a skill or power you have that the person sitting next to you doesn't? You think you are the one who does that. Unique. Like what you do best. What you do best. For anything. You do something that he doesn't know how to do.
um, the information that I know about the case.
Okay, you talk about dentistry. Fine. We can stick to dentistry, but I'm sure what is your favorite food that you cook? What is it? Or you don't cook?
Meat.
Meat? Do you know how to cook meat? See? There are something that she is having the power and doing it the best that the person next to it doesn't know. And so forth. There's so many things that Anas only knows how to do. Yeah? or only Muhammad knows how to do. Correct? Now there is another power that we normally are not developing because of our dentistry. That was not a subject. And that power and that skill is the power of when. We are not trained to know when is the best time to do what, because our training was whenever the patient walks into the clinic, if they have a decay, what we do?
Restoration.
We restore it. If they have an infection, we do a root canal endodontic treatment. If they have a mobility plus 3, we extract it. Correct? We have been trained to diagnose and action treatment. Yeah? So the when was always based on the patient's visit. With implant dentistry, the patient will come to you way before you the total plan. They come to you way earlier and you tell them, I need 9 months of treatment. So you have 9 months or 6 months or 3 months to complete the treatment. In that 3 or 6 or 9 months, if you have the power of when to do what, that 9 months can be a very productive 9 months, or it can be 7 months, or it can be uh, a more, uh, the prognosis will be higher versus another person who has the power better than you. So this is a skill that we need to develop in implant dentistry. The power of when to do the augmentation, when to do the implant placement, when to do the uncovery, when to do the soft tissue graft, when to place a membrane, all is a new concept because you don't do implant treatment the way you used to do general dentistry treatment, which is immediate. Everything is right now. Okay. Now you can open your look at the paper in front of you, grab on the mandible. Now from now on, please that you should with you should have that in you. Only this one. You only need this. Ah, that's him. So anything you think is going to be slowing you down or making it more complicated in terms of treatment, please add it in the drawing. Okay. Now, most of these muscles are not really relevant to placing an implant. Can any of you tell me which of these muscles at the time of intraoral examination, you remember second step, which of these muscles actually you might be testing or feeling for? Why would you want to test them? No, in your favor. I mean, something that you are actually going to benefit from testing. So how you will test it, and why would you want to know about the masseter?
Hyperactivity of the masseter muscle
How you test it?
by placing your fingers inside.
Okay,
Open.
open or closed? Okay. There is only opens your mouth, which is, and which you cannot put your finger there. Why you cannot put your finger there? For lateral pterygoid. Where is lateral pterygoid? Okay. You hardly can. It's very difficult to. and you really don't need it. Because if the patient can open, enough. But masseter is important. Why? Continue. Then,
So the attractive like insert excess.
and you are expecting what? Is closed muscle, right? It suddenly becomes, you touch this and the patient is closing. Even from outside, you can feel it. Put your finger inside. You can, though. See, patient closes and you find like really hard and suddenly bulging out. That tells you that, and how will that affect you? Will it affect you uh, in the position of placing the implant? No. So exactly. So one, it will tell you maybe about the dimension of the implant. You are probably are not placing diameter implant in the first molar for such a patient. You need a normal average. You don't want something thin and breakable, but it will definitely keep you in mind that maybe zirconium abutments are not very good choice for this kind of patients. First of all, aesthetic is not a concern. Second of all, with so much exertion of pressure, maybe you want to be more of a metal kind of titanium abutment selection category. I just, I'm just saying, most of the muscles you see on the screen are not used for diagnosis at this stage. Probably you will place your finger. Wait, let me go lingual. Probably you'll place your finger. I feel gagging when I put my finger so deep. So the patient is expecting your finger to be there in their throat. Why would you do that? You want to place your finger here at, to categorize or classify the depression. We have class 1, class 2, class 3. Okay, in class 1 it's flat, then it becomes like in class 3 it's very huge. So even though you can have access to a CBCT, but there should be a legitimate reason for a CBCT scanning, correct? So if you find everything is flat and you're placing a single implant, probably maybe you don't want to put the patient into a CT scan diagnosis. That's why this becomes very important for you to, first of all, with your fingers. Where else you want to examine? What else you want to examine here? Lingually, in second step, intraorally. Yes, okay. Where else will be a concavity? Where else you will find a concavity? Yeah, but where you expect to look for a concavity? Okay. You're looking for here, you mean? Okay. Yeah. So mainly concavity you want to check here. Okay. And also you want to look for any bone exostosis, because that can be a helpful when you put your, sometimes you miss it when the patient is smiling and opening, you don't see it. But when you put your finger, you'll find this extra bony parts, and suddenly you think, oh, I have a reservoir, I have a mine. Anytime I can take it, crush it, and use it in case I need some support or I need some autogenous bone. Cortical bone, it's not cancellous, but still, it's patient's own bone. Or it might be in your way if you're giving a patient a removable prosthesis as a temporary, so it might hurt the patient. That's why you want to look for those exostosis. Uh, you know what I'm talking about? Yes? Sorry? pectoral. These are some other, now we leave the muscles and we look at other structures that could be in your way for examination. What else, graph, you think you want to look into it or you want to pay attention to it, surgery? Mental foramen, we talk about here. What else? Facial nerve. Facial nerve is coming here, facial artery, I mean. Okay. Facial nerve can come here, part branch of it. Yes, it can come here. Why would these three things be in your way? How would this be part of your, like, how can you harm these three?
When you are removing a flap,
When you're removing a flap, okay. If you go that deep at the corner, in case you want to harvest some bone from the ramus, there is a chance that you go to the angle in front of this area. Anything else? You're going to most of the time cut and forget about it. See, you definitely are going to damage this muscle whenever you are reflecting lip. Welcome. Whenever you reflect, if you suture it, it's going to form back. This area will be, but there is not much mandible except the alveolar nerve and artery. You are really have to be careful with. There is one more area that is slightly become more important. Yes, in the lingual part of, you'll see more photographs on it where you want to pay attention to that area, and that is only detectable by your CBCT view. Otherwise, luckily, there is not much structures, even though of 5 categorization of the 5 complexities of the jaw in terms of placing the inferior alveolar is to be accessible to your injury, but if you avoid it, there is not much more things to be worried about. So we're looking at the mandible. This is how it looks. This is the of patients who come to you asking for implants in different parts of the mouth. Now, if you look at the mandible, posterior mandible, yeah,
Regarding the anatomy, I was reading something and it was saying that we should be careful from the mandibular perforation and it will cause hemorrhage.
yes, we will come to that. We have a full part in that in this lecture. So this one, just for you to know the type of patients that come to you, all right? This is for the anterior mandible, okay? 14% in one study that we did, and another study, 4% of the population that come to you, they need anterior mandible. Posterior mandible is the highest. So expect most of the patients that come to you, actually, they are coming for the posterior mandible implants. If you just want to know more, this is the premolar area without sinus or smaller. This is your maxilla. So a lot of people will come to you for the anterior maxilla of patients population. So if you want to gear up to be familiarized with the is highest. This photograph will help you also to understand why 15% of the patients have, population I'm talking about, they are without their tooth number 46. 15% of the population who are edentulous, 15% of them are missing the number 15. If you add up the posterior mandible together, it will be 33%. And if you add up the anterior, it will be like 30%. If you look at the central alone, is slightly higher than the first molar. But if you look at the whole anterior maxilla versus posterior mandible wins. You know what I'm trying to say? Individually, central incisor will be the highest number of patients that you will see individually, not as an anterior maxilla. As an anterior maxilla, first will be the posterior mandible, second will be the anterior maxilla. But this one tooth and this first molar will be the highest chance of patients who come to you in your career. So if you want to improve your skills, these are the two most implants required in population. Yes.
This depends on article review or from experience in the clinics.
No, this is already published. We published this already. You can Google.
Yeah, but where?
Which country was this taken from? This was based on in UAE, 4,600 patients. Yeah. All right. Now, when you look and you take a panoramic view, you'll see a straight line at the bone level. Okay. And you do your procedure. Now, if you don't pay attention to the biotype in a young patient with a thin biotype, welcome, there is a very good chance in a panoramic view you will not see this. Even in a periapical view, you will not see this. You will only pay attention to the bone level, which is a straight line at the CEJ. And CBCT, you will mainly pay attention to the mental foramen and you plan the case. But when you have a thick biotype patient, generally they will have this kind of bone around the neck of the teeth. So there is a lot of time, there is a chance that you are not expecting this thin bone in the mandible, in the labial surface. Many times it happens that you extract and you do immediate placement. Many of you are interested in immediate placement without a flap, which is good, but you shouldn't avoid checking for this. Now, this photograph is just to remind you, every time you extract an anterior mandible, check for where the bone starts. And that should help you in placing the implant accordingly, or doing augmentation or not accordingly, and checking the biotype in these cases before you extract. So expect this for the thin biotype and expect this for the thick biotype. And this part, if the implant surface is contaminated or touched by the soft tissue, you could have a very good primary stable implant in the anterior mandible, which is the highest success rate, and you have failure. Not open a flap. You did immediate extraction in a canine, which is fantastic, and you didn't look for any dehiscence, and you placed an implant. The primary stability is fantastic, and you told the patient guaranteed for life. The patient goes, and after you load that implant, because this takes time for it to fail. This is not an immediate failure. And then after a while, this fails, the implant fails because of this part that you missed. And this titanium was touching the soft tissue. You just take a blunt probe, like a perio probe, and you go inside the socket and keep coming upward, and you'll find that you are touching a soft tissue. From outside, you can feel the soft tissue with your finger. As you go up and down, you basically scan your perio probe, a blunt probe. Have once you have a communication between the soft tissue and your socket, I'm sure you're not going to put the implant without paying attention. The implant should be more lingual, and you want to put some bony material there for the immigration of the granulation tissue and soft tissue will not go through the hole and touch the surface of the implant. But if you don't know there is a communication, you'll just put the implant of the posterior mandibular teeth. And this is how the bone looks like. And this is how the internal nerve looks like in a panoramic X-ray, correct? Now, do you see this radio-opaque line? Do you see it here? Correct? All of you think, I'm included, that this border and this border are having thick bone. The opaque line is going to infiltrating because I see a radio opaque line. In some X-rays, you see even the top part is radio opaque. So you have two lines determining where this canal is. But when you look at the actual mandible, there is no such thing. So how did this radio opaque line, this illusion, form? And if you want to guess of exactly the curvature is making it look like it's radio opaque and it is harder. There is nothing hard about this compared to this. It's exactly the same material. Actually, maybe it's worse here. But because of that curvature and the superimposition, it looks, sometimes it gives you the illusion of a white line, which you might think this is hard bone. The canal is protected by a hard bone. It's not. So it's very easy to enter this area. There is no protection. There is no radio opaque, no cortical border at all. Actually, the reverse. It's worse. See? It's not even a straight line in reality. Many of us look at that pipe with radio opaque top and bottom and think it's safe to drill close to it. It's not. Then you are safe because the nerve doesn't have to be at the top border. Sometimes the nerve is sleeping border. I mean the whole bundle. It's at the top. You don't electrical wire is there. Maybe buccal. I'm saying even if you are touching the roof of this canal, the nerve is not always in the superior position of the canal. Yeah, it's not the nerve, it's the whole bundle. The artery and the... Yeah, that means the bundle was either at the lower border or your buccal or lingual to the canal. This is another misunderstanding that we have. Basically, we think there is one inferior alveolar nerve, and there is one inferior alveolar canal, and one big nerve, and that's it. So if I'm drilling here, and the patient is shouting, I must be too close to the nerve. Many of us feel scared when they are far from the canal, and the patient is patient is stopping you by holding your hand, say, doctor, you're hurting. Already give infiltration once and twice and thrice, and the patient says, I have severe pain. So you give a short implant option to the patient because you are have destroyed the nerve. This photograph will show you there are so many accessory nerves inside the mandible which you don't need it, and they're not going to cause numbness, and they're not to have any side effect on the prognosis of your implant. If you can anesthetize them intraosseously, please, and continue your work, because this is the one you want to avoid. These ones are accessory nerves. The only problem with them is if 1% of the time they get encircled around the implant, wherever they are inside the threads, in that area there is no osseointegration because it's a soft tissue, it's not a hard tissue. So the person angle drilling already cleans, takes care of that part. I'm just saying very rarely it could happen, but mainly if you are checking your radiograph and you are far from an inferior alveolar canal and the patient is complaining of electrical pain, then this photograph should come to you. Have you seen this photograph earlier? This is very helpful. Okay, this is another misconception. This misconception happens because we think the mental foramen, and where the nerve is coming out, they are in one line. We think this. So when we place the implant in a periapical X-ray, because the mental foramen is here, and the implant, we don't want it to touch the mental foramen, okay? We put the implant above this. Then we get to have a very short implant. Actually, the nerve is here. The nerve is not here. Here, but you can go as close as 2 millimeter safety zone from here. But in your X-ray, the radiolucent area is here. So if you want to be 2 millimeter above here, in a very short way. So be careful where the nerve is to exit is much labial to where your implant is. So the nerve is coming out mostly like this. So you still have room to go. So if you see the mental foramen implant on the same level, don't panic. It's not a dangerous thing because the nerve is below that. Any questions? Yes. Point is, don't panic. As he said, the patient has zero pain. Everything is fine. In your X-ray, with your first drill, the tip of the mental foramen and the tip of your drill is at the same level. And you are taught to keep 2 millimeter of safety zone, right? So you go, you say, oh, I'm too deep. Let me go 2 millimeter higher. No need. There is no need for that. So basically, you still have 2 millimeter of safety zone. Of course, this is not for every patient. Always you have patients with different, and I'll show you different patients which contradict this. But this is generally what happens. Now, I'm trying to explain the same concept. The implant is here. You can see the mental foramen, and we are above the mental foramen. Okay, who was reading last? Who was the last person who was reading? You were? Please. Read the sentence first. What do you think the empty word is? The cancellous bone in the body is the mandible? The cortical? Okay. Next. No, next person who's using his mobile. Second line. Read the second. You want to guess? Okay. We talk about the muscles, okay? You talk about the teeth or muscles? Okay. All right. So you want to fill up the gap? No, Bahrain. Approximately, how many kilogram you think you're applying? 15 kilo. Anybody wants to add? 6? 16? 60. Okay. Anybody else? 100 kilogram. Oh my God. Okay. Okay. Let us go to the next person. Yeah. Read the third sentence. How much more? What is the percentage that they are more efficient than mandibles of monkeys? Are they more efficient or same? How much more? Maybe 3%. Okay. Meat. Okay. So 15%. So the first one is the hardest. The second one, you are very close. The 100, was 100. The third one is almost double. So we are double of whom they say we are from. I disagree that we are from monkeys, but even people who claim we are. Yeah. All right. Now, these were the 3 misconceptions that I tried to clean from your mind. Yeah? Those 3 misconceptions. The first one was, what was the 3 misconceptions?
The hard border.
Hard border because of the radiopacity. The second misconception was extrusion of the mental foramen is not the position of where the related to the implant placement. And what was the other one? Yes, anterior mandible is not the safest place which we used to. Now, this is not a misconception, but some of you know this, some of you don't. It helps you to know this, is when in the posterior mandible, when the inferior alveolar nerve starts, it doesn't go on a straight line. It comes out of the mandible. It gives you a help when you are placing an implant and you're looking for going deeper. For example, if you have a CT scan and the nerve is slightly high in this location, and if you can place your implant here, you're safe and you can go deeper because you are avoiding the nerve. If you don't know this and you think the implant The inferior articular canal is going in the middle of the mandible from beginning to the end. You will not think to do this. But if you know it enters here and it is here, then you start looking for, what is the right word? Ditch, duck. I can, like, try to fit. You start looking for the path of the canal. Maybe you can use that in your favor. Implant in case you have less bone above the canal. Is that something helpful, you think? Unfortunately, you cannot do that without a, exactly. So it looks like this, but on a CBCT, it looks like this. So this is good to know. Surgical guide, of course, but CBCT will tell you how to make your surgical guide. Yeah, this one, for some of you who are, yesterday we were doing a case and the doctor did all the 4 drills and then he took the periapical x-ray before placing the implant. And we have repeatedly said this earlier and again and again. At the first time when you place your first drill, that's the time you should take a periapical x-ray, because that's the time you can change the angulation, the position, the diameter, everything. Once you go to the 3rd or 4th drill, that's it. So if you are damaging or you're very close to the tooth, the implant will be at least 0.5 to 0.9 millimeter bigger than your last drill, almost 1 millimeter, correct? So if the diameter of the implant is 1 millimeter bigger than your last drill, if you are close with your last drill, then for sure, what's going to happen? You will hit the nerve or the tooth or whatever. So don't think if your last drill is not touching a structure, then you can place the implant. The implant is always bigger than your last drill. Is that making sense? Okay, good. So please remember this photograph in your mind, and this could have been corrected only because we took a periapical x-ray and we changed the position. Otherwise, if this was leading to the next implant, next diameter drill, and next, this would definitely have caused the to be. What happens if I touch to? So what? No, yeah, exactly. You don't know what's going to happen because the tooth is not vital. All right, it might touch the cementum, it might touch the dentin. You don't know which part of the tooth is going to be traumatized. If the periodontal ligament gets inflamed, then it will continue because there is no remedy to clean it. So then it will lead to mobility and periodontal defect and extraction of the tooth. If it's non-vital, mostly it needs a root canal. So it's unnecessarily a complication which you can easily avoid by taking this periapical x-ray. Punishment? Management. Oh. I heard punishment. No, if you do the first drill, this is the first drill, we change the angle, finished. With the drill or with the implant? With the drill? No, then you stay away from that area, okay? And let the inflammation take care of itself. If you can, no, you continue. If one drill hit it with a periapical, you can do anything to stop what you did. So you place your implant where it should go, far from this area, and let this heal. If there is any treatment required, we will do it eventually as an iatrogenic treatment. But we will not stop the implant placement, because anyway, the implant should not anywhere, should be placed here. So we will put the direction properly, and we will place the implant according to right, and the inflammation will take care of it. But if you place something, if you place the implant, then the inflammation cannot take care of the repair because there is no to heal. The reason I'm showing you the tomogram is we could see that there is concavity, little bit, not much. Actually, it's a pretty straightforward case. That's why the doctor thought, since there is no cavity, and with human eye, this was straight. But the periapical X-ray proved that your eye is looks straight. That doesn't mean it's actually straight, because sometimes the patient most lying down, correct? So that straightness is no longer a perfect measure. And the curvature of the canal here, what's the difference? Yeah. So if the patient has this you can place, it doesn't mean all the patients will give you this angle. Some patients straight canal, a standardized thing that will give you an angle for implant here. But use it. But if you if that is not matching the parallelism of your teeth, then for you, because you still want to place your implant this way, correct? So look for it. If you want, it's in your use discretion to place a longer. Yes. No, this is not very close. This is 1.5 millimeter, which is accurate. You want to keep 1.5 millimeter space from the neighboring teeth. You don't want to keep a longer than 1.5, be shorter than 1.5. Is ideal, because if you're more distance, then the tooth a room for food to fill up, create. And if you're closer than 1.5, then for the circulation and for the body to maintain its own lymphatic drainage. You want to have an papilla. 5 millimeter is the best space. Like how close you're sitting to Dr. Asha on your left. There is a distance, right? Why that distance? Why not more? Why not less? For some reason, both of you felt this distance is acceptable, correct? If you reduce that, they just reduce. I promise after 5 to that position. See? Why? Tell me why. There is a space for the cellular biology to maintaining themselves. So that was found to be 0.5. Should take a break?
I was thinking